Morning, Miss Rahman.
Morning. My lady, may I call the first witness, Professor David Osborne?
Would you please repeat after me? I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Please, please.
Good morning, Professor.
Morning.
Please, could you give your full name, please?
Yeah, my name's Professor David Osborne.
Thank you.
Thanks for coming along to help us, Professor Osborne.
Thank you.
Professor, if I could just ask you to keep your voice up. We've got a stenographer writing down everything that you and I are going to say, and that will help.
Sure.
Professor, you should have in front of you a copy of a report with the reference INQ 000588211. Can you confirm that is an expert report that you've provided for the purposes of the inquiry?
I can confirm that.
Thank you. And can you confirm that any facts stated within the report are true to the best of your knowledge and belief?
I can.
And can you also confirm that any opinions that you've stated in the report represent your true and professional opinion?
I can.
Thank you. Now, Professor, I know you've got the copy of your report. As I ask you questions, I'll give you the paragraph numbers just in case you need to refresh your memory at any point. It's a very detailed report. I'll also be putting up on the screen in front of you just a few slides from time to time, and I'll let you know when that's happening. So, Professor, turning first to your professional background, which you deal with at paragraph 2 of your report, you're a clinical professor of psychiatric epidemiology at University College London.
Correct.
What does psychiatric epidemiology entail?
So psychiatric epidemiology is particularly involved in looking at patterns of mental health problems. Relating to this report, particularly we're interested in patterns of severe mental illness, and we'll often use large data, particularly NHS data, to look at things like inequalities, but also look at treatment outcomes for people with severe mental illness over time.
Thank you. And you're also an honorary consultant psychiatrist at the North London NHS Foundation Trust?
I am.
And your clinical work, as I understand it, Professor, covers general adult psychiatry and acute crisis teams for people with severe mental illnesses.
That's correct. And I worked in those crisis teams during the pandemic.
Thank you. You've also led and published wide-ranging research on physical health problems in people with severe mental health for more than 20 years, as I understand it.
Correct.
And finally, you've contributed to the international and national clinical guidelines on the management of these patients.
That's right.
Thank you, Professor. Professor, at page 4 of your report, just briefly touching on your detailed instructions for the report, you say that you were instructed by the inquiry to provide a report on the impact of the COVID-19 pandemic on mental health services for people with severe mental illness.
Correct.
And you explain that you've reviewed regional, national and international literature for the purposes of your report.
That's right.
And I think you may have contributed to some of that research. Part of your team would have responded to some of those studies.
Indeed.
Thank you. And just finally, you've acknowledged at the same page the contribution of Jennifer Dykehorn, whose research focuses on severe mental illness in socially excluded and historically marginalised populations.
Yes.
Thank you. Professor, moving on to the substance of your report, at paragraph 2, it's right to say that there are a number of different approaches to defining severe mental illness.
It is.
Now, we'll be hearing from another witness, my lady, Professor Dashmuntsi, more on that later. But the purposes of your evidence, at paragraph 2 of your report, you've given some examples of the sorts of conditions that are included, and you mention schizophrenia spectrum disorders, other psychotic disorders, bipolar disorders, eating disorders, personality disorders, and severe depression.
That's correct.
And Professor, is it right that people with these sorts of conditions tend to have a high need for mental health services?
It is true. They're often in contact with particularly secondary care mental health services, but also use primary care services a lot.
So GPs and hospitals
Exactly.
would be providing quite a lot of care to people with these conditions.
Exactly.
And why is that? It may be obvious, but why do they have such a high need for these services?
Well, particularly because of the mental health symptoms that they experience. They can include things like hearing voices or perhaps having abnormal beliefs, for instance, being paranoid. Others have quite severe presentations with either low mood or at times with elated mood. So a range of presentations that affect areas of their daily life, and they require specialised treatments for those.
Thank you. And so it would be expected then that any disruption to services, such as may have happened in the pandemic, or their access to the services, that would have a significant impact on people like that. Would that be fair to say?
That would be fair to say.
Now, before we discuss your findings about that impact, I just want to ask you a little bit about the nature and the quality of the research that you reviewed. You flagged at paragraph 8 of your report various limitations. For instance, it's right to say there was far less evidence about mental health services in the later waves of the pandemic. Is that correct?
It is correct. We found far more evidence in the early stages of the pandemic published rather than as things moved on through the months and years.
Thank you. And also you say there was less evidence about some specific conditions. So, for instance, severe obsessive compulsive disorder. So there were a few things that you didn't find that came up so much in these studies.
That's correct. We tended to find that the research was about groups of people with severe mental illness rather than specific diagnoses, although we did look for that evidence.
So that's just one example of a data gap, which is a concept the inquiry's heard quite a bit about. Whilst we're on that point, I don't need to take you to it, but right at the end of your report at section 6, just to touch on this, you say that whilst you found a large body of evidence, little was available using representative populations, and much was published on single sites or convenient samples. Could you just explain what you mean by that?
I can. There were some strong pieces of evidence, but that were from, for instance, particular NHS provider trusts, so mental health service providers, but of course they were one provider, and so it would be difficult to always say that those results could be generalised all across the country. However, there were other pieces of evidence that had far more providers, and indeed some studies with national evidence, so they speak to each other to build a bigger picture.
Thank you. Finally, just in terms of limitations, you also say that there were fewer studies from Wales, Northern Ireland and Scotland, though I think you have referred to some research from those areas in your report.
That's correct.
And again, Professor, despite the caveats, it's right to say you have reached some findings and conclusions on the basis of the evidence that you've reviewed.
Absolutely.
Thank you. Well, I'll just take you through now the main findings that you've made. The first section of your report is changes in demand for existing mental health services. So, Professor, you've explained to us that in normal times, these sorts of patients would have a high demand or need for mental health care services. But in this section of your report, you explained there was a dramatic reduction in people presenting to mental health services during the pandemic.
That's right.
And just to illustrate, if I could ask for figure 1A to come up on the screen. It says there, psychiatric presentation. So this is a study that you've reviewed. Could you just explain to us, there are two charts here. One says psychiatric presentations. In a moment, we'll come to one that's A&E presentations. What's the difference between a psychiatric presentation and an A&E presentation?
So we've got people who've been referred for an emergency psychiatric assessment in one, and we've also got people who've attended an accident and emergency department with a psychiatric emergency. So we see a similar pattern in both of those types of presentation, which is that as we went into the very first wave of the pandemic, there's this huge decrease in 2020, which is the orangey yellow line,
Yeah.
where we see a big decrease in people presenting, and the top line just shows the year before the pandemic, shows that normally there wouldn't be much variation. So it was very striking.
And we also see that in November, don't we?
We see that,
the second
exactly.
lockdown.
Exactly. A huge decrease again.
Thank you. And then if we can go to the second slide, figure 1B, we see the same sort of pattern, do we? March into April and then November, and that's people coming to A&E and seeking help for these conditions.
For these conditions, exactly. A decrease at both time points.
Now, in your report, you've talked about the sharp reductions that we see on that graph aligning with lockdown periods and public health messaging encouraging people to avoid hospitals and observe travel restrictions. Can you expand a bit more, if you're able to, on the impact of public messaging on people with severe mental illnesses?
I think, as you describe it, people were perhaps less willing to go to emergency departments and also fearful of travel and obviously not wanting to breach the rules, and that perhaps explains why people were less likely to go to the emergency department, as well as hearing how overrun the emergency departments were with dealing with the presentations from the COVID pandemic.
This is, as I understand it, these two graphs and this study that we've looked at, it's from 3 acute mental health liaison teams and 2 acute mental health centres in England.
It is.
Does it fit with your own experience? I'm looking at these sorts of reductions, very sharp reductions.
It does, and in the later evidence it also fits with the fact that some of these presentations would then generate people needing to go into hospital, and in the later evidence we see a big decrease also in the number of people who were admitted to psychiatric hospitals in the early stages of the pandemic.
Thank you. I want to move on to a different topic or a different feature that you flagged in your report at paragraph 15. You say essentially that those who did present had more severe symptoms compared to what you'd see before the pandemic. We're going to hear more from Professor Dashmunchi about specific impact on symptoms. But are you saying in simple terms people were leaving it later to seek help during the pandemic? Is that what you're describing there?
It is what we're describing there. I think we saw that people had left it longer to seek help for their symptoms, and we also saw that people were there were more people with severe presentations who were being seen in what we'd call the caseload or the case mix of people presenting.
Yeah, and that, as you say, aligns with public health messaging at the time, sort of on the theme of don't burden the NHS unless you can absolutely sort of avoid it.
Exactly.
Okay, thank you. Can I move on to another topic now, Professor? That is in your report, again from paragraph 15, you're talking about involuntary admissions. Now, in simple terms, is it right to say that an involuntary admission is one where the person concerned is detained on a compulsory basis for treatment under legislative powers?
That's correct. It's under use of a Mental Health Act, so that people are admitted and not consenting to the admission.
Sometimes you call it a detention, is that
Yes.
correct? And you say that involuntary admissions or detentions increased according to both an English and a Scottish study that you've referred to. Is that correct?
That's correct. Yes, we saw increases in the proportion of people who were under this legislation and admitted.
And do you consider that the increase in the admissions was in part also a feature of what you have described earlier as people presenting later, essentially in crisis?
I think that's absolutely one of the likely explanations for that. possibly that people did not want to go into hospital voluntarily because perhaps of fears of infection and what the situation would be like on the mental health wards.
And now, at paragraph 16 of your report, you also refer to an additional study that Professor Dashmunshi has mentioned. I think it's the Hildersley study. I'll ask her about it later. But to pick up the point with you, the study refers to higher rates of involuntary admissions in Black Caribbean and Black African groups. And am I right to say that the Scottish paper that you referred to had similar findings?
That's correct.
And that's during the first lockdown?
Exactly.
You explained that higher rates of these involuntary admissions for some ethnic minorities were already a concern before the pandemic?
That's right. There's a strong body of evidence that shows that there are increased mental health detentions among some particular ethnic groups, and particularly Black and Asian ethnic groups.
But the way you put it is that this ethnic inequality in involuntary admissions was exacerbated by the pandemic.
It was.
And do you say that because, as we've seen, the studies are showing higher numbers of people being detained with higher rates from these ethnic groups?
There were a greater proportion of detentions amongst people from Black ethnic groups, if I'm understanding you correctly.
So, in summary, there is evidence of higher rates of some ethnic minorities being involuntarily detained, according to those studies. Just a couple more points on this point, on this area. Would it be fair to say that when people were detained during the pandemic, it would be more difficult to actually provide them with the treatment for which they have been detained?
I think there's strong evidence that people were concerned that treatment on particularly inpatient units was very challenging to provide, to elaborate, particularly because there was lots of course, lots of emphasis on infection control on the wards, and that made it more difficult for people to feel they could offer therapeutic interventions to people, often people needing to socially distance, so not being able to have social contact and to have therapeutic contact that would be part of normal inpatient care.
So you have a situation where people are being detained under these powers, but in fact the treatment that's justified that is very challenging to provide during the pandemic.
It was certainly more challenging with all the restrictions to control infections.
And they're also being exposed to the sort of specific infection risks that you've described and we'll come back to.
Sure.
Thank you. Just to then tie up on this area, you've just described to us the increased involuntary admissions. But you also say at paragraph 15 that there was a corresponding decrease in voluntary admissions.
Yes.
We've already touched on people not wanting to come in so much, but you also say that mental health professionals may have been more cautious about admitting people, even if they did attend. Why would that be?
Yes, I think there's certainly factors to do with the individual service user, but also in the health service there was people were concerned not to expose people to risk of infection by them being in hospital. There were also concerns about capacity as people weren't sure what was going to evolve in that very early wave of the pandemic.
Thank you. Just a final point on this section. You say at paragraph 16 that when people did present, there's some evidence that slightly fewer of them were being discharged without any follow-up being necessary. So follow-up could mean community referrals or other form of support. Is that right? Not just being admitted?
Exactly. So with less community follow-up.
Sorry to interrupt. Going back to your point about capacity, Professor Osborne, I've heard a lot of evidence about the redeployment of particularly medical staff. Did the mental health services suffer redeployment?
There were some concerns about redeployment. I think there was also huge concern about absence of staff because of people having to isolate and to shield, and especially in those early days where we didn't have testing available. So there were large decreases in staff numbers.
Sorry to interrupt.
No. On the issue of at least some care being required when they did present, is that also consistent with what you've said about people presenting a bit later with more severe symptoms? So less people being told, in fact, you don't need any further treatment at all?
Sorry, could you repeat the question, please? I'm not sure I fully understood.
I think that what you've described is that you've got fewer people in the pandemic being discharged with no further treatment being required. And I just wondered if that's consistent with the fact that people are presenting with more severe symptoms, so some sort of treatment is required.
Yeah, I'm not sure I follow that, sorry.
I'm sorry. Well, it's not an important point. What is the significance at paragraph 16 of the evidence that slightly fewer were being discharged without any follow-up? Or it's simply something that you've observed without much significance?
It's something that we've observed. I mean, obviously there were as the rest of the report shows, there was a lot less availability of community treatment for people with severe mental illnesses during lockdown, with a big move towards telemedicine and non-face-to-face contacts.
Thank you, Professor. Professor, your report then turns to a number of different mental health care settings. I won't go through all of them in detail. They're set out at paragraph 19 to 38. But as a broad proposition, would it be fair to say there's a pattern of reduced presentations to inpatient wards, GPs and community mental health services in the first wave of the pandemic?
I think that's correct. There's a striking decrease in presentations across different services that are described.
And you also identify research which found fewer referrals to secondary services for adult mental health, including older adults.
Exactly.
Now, you've explored all of those settings in depth in your report. I just want to pick up on some specific points that you raise. Paragraph 20 of your report, you talked about rapid discharges, and you refer to a particular paper from one trust that looked at these rapid discharges. And as I understand it, Professor, it was looking specifically at whether or not those patients suffered any acute relapses or negative outcomes like self-harm or being readmitted in crisis. Is that correct?
Correct, yes.
And I think it's right to say that those negative outcomes in this study weren't observed.
They weren't observed, no.
But you point out that this is a single-site study, and you also consider that it is possible that the adverse outcomes weren't picked up because of pressure on community services. Is that correct?
That's completely correct, exactly. It may be that the same factors which were preventing people from seeking help in the first place, also when people were discharged, perhaps they were less likely to seek help, and so we didn't see the outcomes that you mention occurring. But I agree with your observation that it is one mental health provider, albeit a large one.
Thank you. You have mentioned community health services. In the literature that you looked at, did you find or see any specific evidence about how effectively community mental health services were able to operate?
I think there were real concerns that that community mental health services were challenged, particularly with complying with all of the restrictions. And although they tried to carry on, there was a rapid shift from seeing people face to face, which would be normal in mental health care, to using video or telephone consultations instead.
Thank you, Professor. Going to move on now to quite an important point you make in your report a couple of times, starting at paragraph 22. And this is this concept of rebound, inpatient admissions rebounding after lockdown, and slightly fewer discharges as well. Does that mean that more people are going to be on inpatient wards, essentially?
I think that's right. As the restrictions were lifted, we saw that more people were then referred and admitted onto wards, and and people were perhaps, I'm not sure, but healthcare professionals on the wards were perhaps not pushing to discharge people as quickly.
And you referred in your report quite a few times to an unmet need and a treatment gap for the periods when people were not presenting. Is it right to say that you consider then that during this period when people weren't attending, they were clearly still suffering from the mental illnesses and they needed the care, and the treatment gap describes the fact they didn't receive that care?
I think you describe it correctly. People had ongoing mental health problems, and there's lots of other evidence showing that they had ongoing symptoms, and Professor Dash-Munshi will talk about that, but they weren't receiving the care in the community during those periods.
And you would say that the rebounded admission supports there having been that gap?
Absolutely.
Yes, and you cite in your report, paragraphs 29 and 38, a Care Quality Commission report and also evidence of high levels of calls to the NHS England mental health hotline. Is it right, Professor, you say that also supports that there was a high level of need despite the drop in presentations?
Yeah, I think that's exactly what it describes, that people, these are long-term conditions often for people, and so the need hadn't gone away, but we have evidence that when these opportunities to seek help were provided, people used them.
Thank you. Another way you've explored that in your report is by looking at some research on presentation to GPs. That's from paragraph 26, and you refer to a study that showed a large reduction in mental health diagnoses and prescription of psychotropic medication and self-harm episodes. I think just before I'm going to take you to a figure on that, you do point out that severe illnesses weren't specifically covered in that paper.
That's correct.
And also that there are quite significant differences in patterns across the nations.
There were some differences in patterns, yes, across the nations.
But the overall picture is illustrated. For example, if we could get up on the screen, please, figure 5 from your report on page 12. Essentially, that is from primary care practices in Scotland, Northern Ireland and Wales. And the larger, thicker yellow line in the background is what you'd expect. And the pink line shows what actually happened in the initial stages of the pandemic. So you see sharp declines. The vertical line shows the date of the pandemic, sharp declines in prescriptions and presentations across the board. Is that a fair
I think that's
summary?
correct. I think it's striking to see the decreases across all these different measures of people's mental health, including the bottom right figure, which is referrals for mental health to mental health services, which perhaps would include people with severe mental illness.
Thank you. And again, you explain that the prescribing levels then appear to rebound after the first wave of the pandemic. Again, that supports the existence of a treatment gap.
Exactly.
We've touched on the public messaging. Another thing that you talk about in your report at paragraph 27 is that people may not have felt they were worthy of clinical attention during this critical time for the country. And we'll explore that and the term self-stigma with Professor Dash-Munshi later. But is this an example of that? Is that what you're referring to?
I think it is an example of that, where people sometimes talk about diagnostic overshadowing, where they feel their mental health problem overshadows physical health problems, but also perhaps feel that it's not as worthy, particularly when all the headlines were around deaths around COVID.
You've also mentioned in your report a fear of infection as another reason why people might not want to attend. Would that have particular relevance to people who are clinically vulnerable or clinically extremely vulnerable, in your view?
I mean, it's hugely relevant. People with severe mental illness, as you'll hear from Professor Dash-Munshi, but that we have lots of evidence that they have lots of coexisting physical health problems, respiratory problems, cardiovascular problems, so that people with those conditions would be particularly more at risk of having poorer outcomes with COVID.
Thank you, Professor. Professor, pausing now just to consider what lessons can be learnt from what you've described. Do you think that the risk of a treatment gap for those with severe mental illnesses should be recognised in devising public health messaging in a future pandemic or civil emergency?
I think it's important that we recognise that people didn't receive the support and care that they required, and particularly when they're in vulnerable groups.
And can you think of any practical steps that could address that risk, that public messaging inadvertently discourages people from seeking the mental health care that they need?
I think that would be something around the messaging that encourages people to make sure they do stay in contact with their mental health services. I think, perhaps as an aside, but there was similar concerns that people weren't seeking help for other physical conditions at the same time, that perhaps they weren't presenting for very serious physical conditions. So perhaps the lesson learned is trying to really encourage people to keep in contact with the services that they require.
And finally, on the impact of these delayed presentations, you say at paragraph 29 that early treatment is important in achieving the best outcome for those with severe mental illness, and delaying treatment can have long-lasting impacts. Could you expand a little on what sort of impacts you might see in this cohort, people with severe mental illnesses, if their treatment's delayed?
I think certainly we know when people first present with severe mental illness that if there are delays in their treatment, that has a negative impact in the longer term in terms of their mental health and some of their social and other outcomes. So it's a well recognised fact that we need to have people need access to treatment very promptly to try and overcome, for example, symptoms of psychosis.
And does it also follow there's an impact on health services because more care would then need to be provided for those patients in a longer term?
Certainly in the longer term, that's correct, because if people aren't recovering as well, then they're going to need longer term support.
Thank you very much, Professor. I think that's a good point at which to move on to the second part of your report. We've been dealing with need for care, and we're now looking at the changes to mental health services during the pandemic. Again, I'll just ask you some of the main points that you draw out about this. Paragraph 40, you've noticed some instances of specified mental health centres or hubs being opened to divert mental health patients away from hospitals. Do you have any views on that as something to consider in any future pandemic or civil emergency? Does it seem like a good idea to you?
I think it was a very successful intervention, and particularly I have knowledge of one in North London that opened and was particularly successful in providing emergency psychiatric care to people and took them away from the risk of going to the emergency department, but also meant they got specialist care more quickly. Several of those, to my knowledge, several of those centres have continued to exist, offering that kind of specialist care, but it's certainly something that was felt to have worked during the pandemic to offer emergency psychiatric assessment and management.
Thank you. And second, of course, the major change that you describe in your report is the closure or conversion of some inpatient wards in order to provide COVID-19 care.
Yes.
Clearly, that had the immediate effect of reducing the availability of mental health beds, and that would have had an impact on services and patients for, I take it, obvious reasons. However, you have also noted that some stable patients were moved to receive treatment at home to reduce infection risk. Is
Yes.
that correct? And that, again, is because of the high risk of contracting COVID on the ward.
Absolutely. I remember these were very challenging times for mental health inpatient services, wanting to keep the service users safe and opening specific wards where people who were infected could be cared for together. But of course, suddenly if another ward there was somebody infected, then it was very challenging then to reorganise services to try and move people to one of the, I call it COVID positive ward, if you like. So it was a challenge.
You might have seen a more stable person being moved home to reduce their risk of infection, but would the other side of the coin be a risk that what was available at home wouldn't be adequate for their mental health support?
I think there's certainly that risk with all of the evidence that we saw about lack of community follow-up for people. But that, I guess, was balanced against the risk of being infected while they're on an inpatient psychiatric unit.
Thank you, Professor. So I want to move now to infection control for those who remained in hospital. And you've described this at paragraphs 43 and 44. And you said that infection control was particularly challenging for psychiatric patients. Could you expand on that a little, please?
I think there were a number of challenges. Challenges particularly for people who've been admitted and perhaps are very distressed or agitated, for them to adhere to the rules, be they about hand washing, be they about masks, be they about social distancing when they're in a state of mental distress. I think there were also challenges for the staff in being able to manage those things as well, and particularly on the wards, the need to keep places clean and to deal with PPE when it was available, to deal with testing, all challenges that wouldn't be a normal part of psychiatric inpatient care.
So, I mean, is it right to say that the sort of care you're needing to provide is often face-to-face group activities sometimes? It's something you're in close contact with the patients, and therefore any delays in getting PPE, those sorts of things that you've described in your report, they had a particular impact.
I think they would have a particular impact, and we know that from evidence given by large surveys of mental health staff about their experience of the pandemic, and they found this really impeded their ability to have therapeutic interactions with the people they were caring for.
Thank you, Professor. In terms, again, of lessons learned from that, are there any specific measures that you could think of that could alleviate some of these challenges that you described about infection control for these sorts of patients?
I think, the things that were challenges as we all went into the pandemic at the beginning, things like availability of testing, availability of PPE, training to use it. It's not part of my usual clinical practice to wear masks and aprons and etc. And so the availability of those, the training would be really important.
Thank you, Professor. Can I move now to another topic, which is remote services? Again, a very major change in service provision, a rapid replacement of face-to-face care with remote services. You touch on particular challenges of delivering mental health care remotely at paragraph 43. And then you have, and I don't need to take you to all of it, but just to highlight, you revisited it at section 3.7 of your report as well. Is it fair to say that your broad conclusion on this is that rapid transition to remote consultations was seen as a success, but it wasn't suitable for all?
I think you're correct. There's national evidence and local evidence and evidence from staff that there was a massive shift to this type of work. However, it was new for many mental health workers, and it was felt to at least fill some of the treatment gap to be able to contact service users in the community. However, there were major concerns about people, particularly vulnerable people, and the suitability of these types of consultations to deliver a positive therapeutic intervention for people. So it works for some people, but not for a large number of other people for a variety of reasons, which I'm happy to talk about if you want me to.
Well, I think you've touched on unequal access to technology and adherence to medication. Are they some of the issues that arise?
exactly, technology, the ability to use it, confidentiality, finding a space to have those consultations, both for the service user themselves to have privacy, but also for the staff actually having space to deliver those confidential interventions.
And just in terms of the impact on the patients themselves, Professor, we've sent you some extracts from the Every Story Matters report on mental health and well-being. And just to illustrate the potential impact, get your thoughts on it, if we could have a slide up with some extracts from accounts. So this is from one or two people. The first says that they sought therapy privately but came up against a brick wall of therapists being unable to take them on as a new client. They've described their no one thinking it safe to see them in person, but it wasn't safe to see them online because of severe PTSD. Does that illustrate some of the issues that you were facing?
Absolutely. I thought all of these stories were really important and moving about both the treatment gap, but also about how these types of remote consultations actually were not found to be helpful for a large number of people.
And the second account there, they say they came close to ending their life. They were admitted to hospital following a suicide attempt, and they felt that that could have been avoided if they'd just been able to sit down, talk to a skilled counsellor or therapist, or in a group environment. Does that resonate with you?
Absolutely. I think, again, this is an example where people were not able to access the care and support face-to-face in the community during the pandemic.
Thank you, Professor. Essentially, these accounts are illustrating some of the issues that arose with this rapid change to online service. Are there any sort of broad, I suppose, rules? Does your research suggest to you there are some circumstances in which remote therapy would always be inappropriate?
I mean, I think several of the reports highlight the fact that care needs to be personalised and agreed between the clinician and the person using the services, and for some people it doesn't work, and that they could be for the reasons that we outlined just before, be that access to technology, be that not being able to use the technology, etc.
So in terms of any criteria that you could consider to determine whether it would be appropriate, it sounds as if what you're saying is that it would be quite case dependent or patient dependent.
It would be case dependent, but I think we've highlighted into some of the types of people who've got particular financial challenges, housing challenges, challenges with technology, where it's really not going to be an appropriate form of support for them.
Were there any alternatives or safeguards that occurred to you as you were experiencing these challenges that you thought, if we needed to do this again, this might help with these challenges? Or was it all just too challenging to think of an easy fix, as it were?
I'm not sure about an easy fix, but I do think considering, as we said, the care plan for the individual person, and sure, if some people did report finding telemedicine very helpful. So, as an example, some people don't like it when mental health professionals come to their home. They feel that it's intrusive. Other people don't want to go to appointments. It costs them time. It costs them money, actually, for them to go. So there were some benefits for some people. But I think, rather than generalise about groups of people, it's about having the personalised approach and seeing whether remote consultations will work for them personally and for the type of treatment plan that they need.
Thank you, Professor. At this point, we are going to hear tomorrow from the mental health charity Mind about some of the initiatives, including digital peer networks. And my lady, I'll pause at this point to adduce a number of statements from charities across the UK that also contain information about both the positive and the negative impact of the move on online services. Only one of which I'll ask you about, Professor, in a moment. Those statements, my lady, are from Scottish Action for Mental Health, inquiry number 000657975, Inspire Wellbeing, INQ 000588200, the Association of Mental Health Providers, INQ 000659785, and finally, the Scottish Mental Health Partnership, INQ 000660114. For your part, Professor, as you've said, you have noted some innovations that were positive. There's one, again, it's a specific psychological intervention, and you describe it at paragraph 55. Is there anything from that example from the Manchester Crisis Resolution Team that gives us an insight into how these services can be made to work online?
I think this was an example of a crisis team offering a particular form of therapy that they delivered, and it's particularly interesting how people did move to bring innovations in, and it sounded successful, as did the other intervention in that paragraph, to try and engage people in physical health interventions when they had severe mental illness. They're small studies, so I think they're hopeful, but they perhaps are things that us in the mental health research community need to think more about understanding their effectiveness and acceptability to people for any future lessons learned.
And just finally, you confirm that according to the research that you've looked at, the rapid transition to digital services is not just something we saw in the UK, but that's an international development.
Absolutely,
in this
yes.
area.
Yes.
Perhaps worth pausing to say as well that at the end of your report, you say that all of your findings at Section 5 applied across the board. Does that mean essentially the trends that you've explained about mental health services, they're consistent with the international picture?
They are consistent with the international literature, particularly decreases in inpatient admissions and closure of community services, or certainly decreases of community services. Perhaps we were better at maintaining services than some other countries in the international evidence.
Thank you. Professor, I'm going to take the next part of your report from paragraph 58 to 59 quite quickly. That's also section 3.6 of your report. And what you're doing there, we've already touched on the impact of on staffing in the workforce, and my lady's asked you a question about it. We've also heard about the impact of pandemic on UK healthcare systems in Module 3. But just in terms of mental health services, it's right that you identify factors like illness, caregiving responsibilities, and some mental health staff being required to redeploy.
Correct.
And you've described the adverse impact on staff morale, stress, burnout and exhaustion. Is that correct?
Correct.
And again, my lady, to note that the Every Story Matter report has a section on the impact on the mental health workforce with accounts from staff. I'm not going to take you to any more of those accounts, Professor, but you go on to say that issue with staff severely impacted on the delivery of mental health services to patients. You say that at
Yes.
paragraph 58. Perhaps the reason is obvious, but could you just explain why those things impacted particularly on patients?
I mean, particularly because some staff were shielding, often in the early stages of the pandemic, where people were having to isolate when they had symptoms. We had huge reductions in staff numbers. So those whole range of factors meant that there was decreased capacity to deliver care to people with severe mental illness.
Thank you. Professor, the next section of your report, section 3.10, touches on specific disorders affected by those changes. I'm going to ask you about a couple of them. The first is eating disorders. Mm-hmm. And it's right that there were already issues with long waiting times for treatment and beds.
Correct.
But again, the research you've looked at suggested that was exacerbated during the pandemic.
Exactly.
And you've said also that the evidence suggests that some were being admitted to general hospitals rather than specialist units.
That's right. There's
What
evidence
would
for
be
that.
the impact of that on a patient with an eating disorder?
I mean, particularly not receiving the specialist eating disorder care that would normally be provided to them. Not to say they wouldn't receive any appropriate treatment, but perhaps less contact with the staff who were specifically trained in dealing with eating disorder care.
You did flag what you've described as a novel treatment at paragraph 65 of your report from the Southwest, and you say it's enhanced cognitive behavioural therapy. And I think you're saying that that study showed that seemed to get a better outcome than traditional inpatient treatment. Are you able to say what it was about that approach that led to that?
No, I think it was, again, it was a small study, but an interesting innovation that came about during the pandemic that was aimed to help to decrease the need for inpatient care, so and seem to improve people's outcomes. So something, perhaps a positive innovation during the pandemic.
Thank you. Moving on to psychosis, that's the other topic I'll ask you about. You address it at paragraph 67, 68, and you note some research suggesting there's an increase in first episodes of psychosis. Is that correct?
That's correct, yes. These are new presentations of people with a psychotic disorder.
So I'm going to deal with this point in a little bit more detail. You note that before the pandemic, there was evidence that the rate of the presentations was higher in Black Caribbean and Black African groups. Is that correct?
That's correct. There's well-established evidence for that.
So a gap between those groups and white individuals. That was already a
Yes,
feature.
it's already a concern, yes.
Now, looking at what happened during the pandemic, you've noted one study, and I'll take you to that in a moment, where, would it be right to say the gap increased during the pandemic for black individuals?
Yeah, that's correct. It did increase. So there was a greater inequality, a larger number of people from black ethnic backgrounds who'd presented with psychosis.
And also, and again, we will look at this figure just in a moment, quite a significant increase in Asian ethnic groups as well.
That's right. There was a...
So let's just have a quick look at that chart. It's figure 12 on page 26 of your report. And I'll summarise, and you can tell me if I get it right afterwards. It goes over 6 years from 2018-19 onwards. The blue column indicates white British, the orange column white other, the green column Asian, and the pink column black individuals. Is that correct?
That's correct.
And within each column at the top is a vertical line with two ends, a bit like an extended capital I, and that's the confidence interval.
It is.
So the true figure could be anywhere between the top and the bottom, but you have, for instance, a sort of 95% confidence that it's somewhere there.
Exactly. That's the area of certainty for the result.
And you take the midpoint as the top of the column.
Yes.
So would I be right to say that the chart shows the highest incident rate for black individuals was in the years 2020 to 21 and 21 to 22?
Yes, that's exactly what it shows.
So around the time of the pandemic, essentially.
Yes.
And there's a significant widening of a gap between the black individuals that were reviewed and the white individuals in the second year in particular.
Yes.
And for Asians, again, it seems it's in the second year. You've got a very significant widening of the gap between them and the white individuals.
Yes.
Thank you, Professor. Going back to your report at paragraph 68, pausing to think about the implications of that, you say that structural inequalities, including discrimination, substandard living, working conditions, that may be an explanation for what that study found.
Yes, I think there's a wide body of evidence looking at this increased rate of psychosis in people from black ethnic groups, and these are some of the factors that are known to contribute to psychosis, which might be more common in people from black ethnic groups.
Well, good to ask Professor Das Munshi about what she says about it. And we're also hearing from other experts on structural inequalities, Professor Bakaris and Nazra, who you refer to in your report. There's also a reference in one of the statements that we sent you, Dania Hanif of the Association of Mental Health Providers. Just to summarise, I don't need to take you to it. That also provides further evidence about higher rates of mental health detentions amongst black people. And it says that in 2020 to 2021, individuals living in the most deprived areas of the UK were twice as likely to be in contact with mental health services compared to those in the least deprived areas. And it describes factors like job insecurity, homelessness, discrimination, displacement, being linked to increased risk of mental health. Are they the sorts of points that you're referring to when you talk about structural inequalities?
They're exactly the kind of points, that there's well-established research around those inequalities.
Thank you, Professor. Section 4 of your report, again, I'm going to take this really quite shortly. You've already explained that massive transformation of services during the pandemic had an impact on patients. And we've also talked about the treatment gap. So you've got people presenting with more serious symptoms. So we see more people with severe mental illnesses seen after the earlier waves of the pandemic. In terms of continuity of care in this section of your report, we've already discussed issues such as remote services, PPE. Are there any other particular challenges you'd like to highlight? For instance, I think you've referenced segregated patients, guidance, difficulty with referrals.
I think the other thing that people particularly mention is continuity of care, and it's something that comes up, outside of the pandemic, but something that people feel has been lacking in their mental health care. And I think we've touched on some of the tele-mental health not being felt to be useful or helpful for people. And people needing to seek help elsewhere other than mental health services was reported in some of the studies.
You've dealt in a lot of detail in your report about the disruption of access to medications specifically. Is it right to say in broad terms the challenges were in terms of monitoring and lack of flexibility around essentially caring for people and prescribing their medications?
Yeah, and yes, and again, I think particularly at the beginning of the pandemic, people having difficulty contacting services in order to discuss medication, be that in the general practice or be that secondary care mental health services, and then a lack of flexibility or availability of clinicians to then consult with people to discuss medication management and monitoring.
Thank you. And at the end of the section, paragraph 81, Professor, you touch on the fact, again, it's something we'll ask Professor Dashmunshi about, there's a higher rate of physical comorbidities amongst people with severe mental illnesses.
Exactly.
A particular point I just want to ask you about, which you make, you say that this meant that people with severe mental illnesses also have a higher rate of morbidities that made them clinically vulnerable.
Absolutely.
And you raise in particular the fear of infection following shielding advice. And I think you say, Professor, you think that might have played a particular part in people not presenting for the care they need, as well as cancelled appointments.
Absolutely. I mean, we've seen a whole range of excess physical health problems like respiratory, long-term problems or diabetes that make people vulnerable and potentially, therefore, in this frightening time for all of us, more reluctant to seek help.
So you've got people who've got a need not only for mental health care, but a real need for physical health care and the fear of infection or
Yes.
following the advice is leading to, again, what you describe as a large hidden backlog of unmet need and long-term implications.
Yes.
Thank you, Professor. Just a couple of more questions about the clinically vulnerable and the clinically extremely vulnerable then. Is there anything specific to them that you can share in terms of access or provision of mental health care? For instance, are you aware of any specific evidence that they were deterred from seeking care due to concerns about PPE, ventilation, other infection control measures? Was there anything about that, or to your knowledge?
Not research evidence that I came across relating to that, but if you're asking about people being extremely vulnerable, many of the definitions of people being vulnerable, such as homelessness or house insecurity, domestic violence, some people who are really struggling with any type of functioning in terms of their daily care, those type of factors are much more commonly seen in people with severe mental illness, and so would make them much more vulnerable, if that answers your point.
And in terms of what might be done, I suppose, in any future pandemic, can you think of any specific lessons to be learned about those who are at the highest clinical risk to reduce the impact on their mental health from the sorts of issues that you've described?
I think if we had time again, we've learned that the people with extremely more severe presentations, people who are much more vulnerable, that they need to be prioritised. So you might kind of think about it in terms of grouping people and making sure that those extremely vulnerable people were not left behind from receiving both mental health and physical health care and support for their social vulnerabilities.
Thank you, Professor. Just a few points to close my questions. At the outset of your evidence, you spoke about certain data gaps, which you set out at section 6. You found research on service provision for those with eating disorders and psychosis during the pandemic, which we've talked about. However, there was an absence of evidence on severe obsessive-compulsive disorders, severe anxiety, depression, or PTSD. What explains the absence of any research on those topics, in your view?
In my view, it was partly because a lot of the research was very broadly about mental health services across the piece rather than looking at specific diagnostic groups. Perhaps that research, it's also a factor that sometimes these diagnoses are not well recorded in some of the in some of our healthcare records. But also, I think a lot of the research questions were around what happened to services rather than what happened to specific diagnostic groups. So the data just weren't collected.
Thank you. Turning finally to section 7 of your report, that sets out some very detailed lessons to be learned from the pandemic, and you set those out under 4 main headings: preparedness, continuity of care during a public health crisis, recovery, and cross-cutting principles. Professor, I've already covered some specific points for learning, for instance, in relation to infection control, online learning, the clinically vulnerable. Are there any other specific points that you'd wish to highlight in terms of the lessons learned?
I think the major concern was about parity of mental health services and protecting them, but also making sure that they had the best chance of continuing to deliver appropriate care, and particularly access to the things that we've discussed around PPE and testing. That feels particularly important.
We'll be hearing some more about that from Professor Dashmunshi. Professor, that closes my questions, but there are some other questions for you from others here.
Thank you very much, Ms. Brown. Ms. Beattie is over that way, Professor.
Professor Osborne, good morning. I ask questions on behalf of National Disabled People's Organisations.
Good morning.
In your report, you explain that the Coronavirus Act 2020 altered the safeguards in place for mental health detention, extended permitted periods of detention, and made it easier to apply for a compulsory treatment order. And you also tell us, and you've given evidence this morning, that the caseload mix in the first waves of the pandemic did change, so that we saw more involuntary detention rather than voluntary inpatient crisis and community services. Disabled people's organisations are concerned that as a result, disabled people were detained where they might have remained in the community, detained for a longer period, and that this contributed to increased institutionalisation of disabled people. How did the changes to the statutory provisions and safeguards impact services and people with mental health illness who needed support?
Thank you. My evidence, just to take the second point about people being detained for longer, we didn't find that in terms of the mental health admissions, but I can imagine that that would be a concern for some individuals, particularly if there was a lack of available community care for them. So I share that concern. I think that the revisions around the Mental Health Act that were proposed, that you referenced, they weren't actually put into place. So there were some real concerns, I think, across the whole mental health community, that there were suggestions that people could be detained perhaps with less, for example, less protections around detention. They were proposed, but they're not enacted. So I think there's a section of the report that talks about that, but them not being in place.
Just to clarify, Melody, I realise I have limited time, but it's right, isn't it, that they were brought in Scotland and Northern Ireland. I think your report addresses that at paragraphs 48 and 49. It's not a memory test, Professor Osborne, but is it right that we did see those measures in those jurisdictions and some changes in how compulsory treatment and detention was implemented there? Yeah,
I think our report highlights the concerns about those, and that they were withdrawn, and that should not be. The recommendation was that they should not be included in future responses to the pandemic.
Thank you, my lady.
Thank you, Ms Beattie. Mr Giudice. Again, over that way.
Hello.
There we go.
Agree.
Can you hear me?
I can.
Morning, Professor. You asked questions earlier this morning about data gaps, and you highlighted that one of the difficulties is that research about mental health services across the piece, if you like, rather than looking at specific diagnostic groups. Sorry, I should have introduced myself. I'm Ms Surges. I represent the domestic abuse group. Just turning to that point specifically, if I may, when considering access to mental health services, do you agree, therefore, that there is a critical need for gender disaggregated data, as well as it being broken down by both ethnicity and gender? So just focusing really on the data gaps.
Absolutely, and a real call for the availability of those data, both in terms of gender and ethnic group, but also as having better data quality, which is one of the real challenges actually in particularly secondary care mental health research, and including, I think, data also from the non-NHS, from the voluntary care sector, to be able to understand what works for people and what doesn't work.
Thank you. I'm going to turn to a slightly different topic. Again, in your evidence and I think in your report, you discuss the benefits and disadvantages of remote consultations. I note in particular at paragraph 56 and 57 of your report, and the impact on health inequalities. And again, just now in evidence, you said that the DA, that the types of factors much more commonly seen in people with SMIs are homelessness and domestic violence, people functioning in terms of daily care, but make sure that extremely vulnerable people don't get left behind. That was one of the points that you made. The DA Group's experience is that some perpetrators of domestic abuse control their victims' access to technology, any technological communications. And so my question is, do you agree that being required to stay at home and subject to a perpetrator's controlling technological communications makes it hard to contact existing mental health support or make new contact with that support?
I completely agree. It's a major concern, and one in the research, but also in my clinical experience, that making sure people are safe from the perpetrators is key, and many of these interventions are therefore not suitable to support people
and therefore
who are victims.
I'm grateful. Just turn to the point that you make, therefore, in your report. Do you agree, therefore, that this would have further exacerbated health inequalities?
I do.
I'm grateful.
Thank you very much indeed. Mr Pisani, now he's over that way. Could you please make sure, you've got quite a soft voice, could you make sure that you keep speaking to the mic?
I will.
Mr Pisani won't object if you have your back to him.
No, not at all. Good morning, Professor. I ask questions on behalf of Mind, the mental health charity. My questions are threefold, but they all relate to the same section of your report, which you have already touched on in your evidence. It's paragraphs 18 to 22, where you describe distinct patterns in inpatient admissions and discharges through the waves of the pandemic, and in particular in relation to the first wave. You say that there were relatively fewer admissions in the first wave and an increase in rapid discharges. You mention at paragraph 21 the possibility that the reduction in admissions could be due to changes to clinical thresholds for admissions and discharges. And you say that it is possible that a result of decreased availability of community services explain decreased detection of crisis from non-admission or rapid discharge. So to the first of my questions, were these changes, in your view, driven by pandemic-related exigencies or individual clinical need, or both?
I would say both of those. I think there was a need to protect patients from admission that might put them at risk of infection, but I think but there were also pressures on the service. So I think each of those factors that you mentioned combined together to affect both admissions and rapid discharges.
Thank you, Professor. My second question is, where community services were attenuated at the same time as there were changes to the rate and timing of admissions and discharges, so that suitable community aftercare might not have been available or as available as it had been before the pandemic. Can you assist on the consequences for people with severe mental illnesses of non-admission or rapid discharge into that relative absence of aftercare?
I don't have research evidence on that, but I think, of course, there's very strong evidence that people with severe mental illness do well from having interventions which involve continuity, seeing professionals, peer support, all of those things in the community, and the lack of those, we know, puts them more at risk of a recurrence, a relapse of their severe mental illness symptoms.
Thank you. And my third and last question, and you said in answer to my previous question, we don't have research evidence on that. Are you able to assist on whether or to what extent we have reliable data on what happened in this period of time to people with severe mental illnesses who either were not admitted when clinically they might have been assessed to need admission, or who were discharged prematurely?
The only evidence was the small study we referenced earlier, which suggested that people who were discharged did not have very severe relapses, but that study did not have good evidence on the service user experience. It wasn't measuring service users' mental health, so I can't give you any stronger evidence, but clearly we heard from many staff and also from service user interviews that they felt that they were not supported during that time, and they reported concerns about their mental health during that period.
I'm very grateful. Thank you, Professor.
Thank you very much, Mr Pisani. Professor, that concludes the questions we have for you. Thank you very much indeed, both for all the effort that went into your report, and I think your colleague also assisted. Could you thank her for me too, please, and for coming along today to help us. I suspect in your clinical work you don't have the easiest of jobs at the best of times, but it must have been particularly tough during the pandemic, so thank you for all that you did.
Thank you.
Thank you very much. We shall return at 11:30, please.
All rise.
Ms Blackwell.
My lady, may I call the next witnesses, please? Professor Claire Bamborough and Professor Sir Michael Marmot.
Would you repeat after me, please? I do solemnly,
I do solemnly,
sincerely and truly
sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
Thank you. Please take a seat. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Please take a seat.
Welcome back, Professors. Good to have you back, and thank you for all your continuing help with the inquiry.
Thank you, milady.
Thank you. Professor Bamborough, Professor Marmot, you should have before you each a copy of your report, which bears the reference number INQ 000588215. Can you each confirm, please, that that is the expert report, the joint report that you have prepared for Module 10 of the inquiry?
It is, yes.
It is.
Thank you. And can you also confirm that the facts stated within the report are true to the best of your knowledge and belief?
Yes.
They are.
Thank you. And that any opinions that you have stated in the report represent your true and complete professional opinions?
Correct.
Yes.
Thank you very much. You last gave evidence back in June of 2023. And I just want to remind ourselves, please, of your professional qualifications. I appreciate we've been through this before, but for those who were not present on the previous occasion, Professor Bamborough, you are a Professor of Public Health, Population Health at the Population Health Sciences Institute in the Faculty of Medical Sciences at Newcastle University. You are an elected Fellow of the Academy of Medical Sciences, the Academy of Social Sciences, the Faculty of Public Health, and the German National Academy of Sciences. You are a senior investigator in the National Institute for Health and Care Research at the Academic College and an academic co-director of Health Equity North, as well as a member of the World Health Organization Scientific Advisory Group on Health Equity in Europe. Thank you. Professor Marmot, you are a Professor of Epidemiology and Public Health and Director of the Institute of Health Equity at University College London, an elected Fellow of the Faculty of Public Health, the Academy of Medical Sciences, an Honorary Fellow of the Royal Society of Public Health and the British Academy, and a Foreign Associate Member of the Institute of Medicine. In 2000, you were awarded a knighthood, and in 2023 made a Companion of Honour for services to public health. You chaired the 2008 World Health Organization Commission on Social Determinants of Health and led the seminal UK government-commissioned Marmot Review, Fair Society, Healthy Lives in 2010, as well as the Health Equity in England Marmot Review 10 Years On in 2020, and Build Back Fairer, the COVID-19 Marmot Review, also in 2020. And more recently, you have been a member of the Global Council on Inequality, AIDS and Pandemics, which is a council composed of global experts proposing evidence-based solutions for addressing inequalities linked to both AIDS and pandemics, looking at how inequalities affect the course of a pandemic and how pandemics exacerbate inequalities. And we shall return to that piece of work at the end of our evidence, if we may. In Module 1, you prepared a report in which you examined health inequalities and the social determinants of health in the lead-up to the COVID-19 pandemic. And you concluded that the UK entered the pandemic with its public services depleted, with health improvements stalled, health inequalities increased, and health among the poorest people in a state of decline. In this follow-up work for Module 10, you have provided an overview of trends in socio-economic inequalities in some of the key social determinants of health during the pandemic period, namely income, poverty, debt, and housing. You then examine the socio-economic inequalities in COVID-19 mortality, in life expectancy, and in healthy life expectancy. And you go on to explore protections and mitigations that were put in place and how those affected society. And finally, you make recommendations for improvements in the future. One point to make before we go into the detail is that you have told us that it's often the case that data and studies are only available for certain areas of the UK. And so your assistance is really determined by the data that you are able to and have been able to obtain. Is that right?
That's correct, and it varies for the different outcomes, and we've made it clear on each occasion whether there were studies available for each of the devolved nations, for example, and stated where we were unable to find any.
Thank you. And we'll come on at the end of your evidence to discuss what improvements should be made in terms of data collection. According to the World Health Organization, health inequalities are a result of disparities in the social determinants of health, the conditions in which we are born, grow, live, work and age. Is that right?
That's correct. I actually wrote that, but yes.
And in your 2010 review, Professor Marmot, did you outline 6 key social determinants of health in the UK?
Absolutely. We drew both on the World Health Organization Commission report that I chaired and a panel of experts in the UK.
Thank you. And those 6 key social determinants are early child development, education and lifelong learning, employment and working conditions, income and cost of living, healthy and sustainable places in which to live and work, and prevention.
Absolutely. May I say we've now added to tackle racism, discrimination and their outcomes, and pursue environmental sustainability and health equity together.
Thank you. Professor Bamborough, you have described how the COVID-19 pandemic was a syndemic. Can you explain to us what you mean by that term, please?
Yes, the syndemic is a way of referring to the fact that the virus interacted with the existing social inequalities in the social determinants of health that Sir Michael's just outlined.
Thank you. And are you also of the view that it's important to note that health inequalities are often experienced intersectionally?
Yes, in our evidence for Module 1, we described how people can have different positions of privilege or subordination in society. Would you like me to add to that?
Yeah.
Yes, so for example, you can experience a class advantage or an educational advantage by going to university, for example, and that leads to health advantages on average over your life course. On the other hand, you might experience disadvantage in terms of by being a member of an ethnic minority or by being a woman or from another social minority group, such as LGBTQ, for example.
Right, so when we're considering health determinants, it's important to look at the full picture and to assess on a case-by-case basis what level of intersectionality that there is.
Yes, in this report for today, we were asked particularly to focus on socioeconomic inequality, but also, where possible, where the data showed, for example, intersections with gender, so if there's variations between men and women, or other aspects such as homelessness, domestic abuse, and so on.
Thank you very much. So let's turn to look at your evidence on social and economic inequalities during the pandemic. I'm going to come to you first, please, Professor Marmot. At paragraph 7 in your report, you tell us that income inequality in the UK experienced a small reduction in 2020-2021, as the lowest income households experienced a small increase in income, whilst those above them had a small decrease. And you tell us that the most likely cause of that was the universal credit uplift. But then, after that small increase, things corrected themselves, and in fact, you saw a trend the other way.
You could use the word correct themselves if you think the magnitude of income inequality that we have is the right level. I don't. Then you could say they corrected themselves. They reverted to the previous pattern.
Perhaps that's a better phrase. Yes. 2021 into 2022, and going further forwards again, 2022 to 2023. Is it right, and this comes from paragraph 84 of your report, that all UK households, except for the highest fifth, experienced a decrease in their real incomes before housing costs? And in relative terms, that was highest for the bottom fifth of households. First of all, can you explain why housing costs are so important in terms of any measurement of increase or decrease of income?
Yeah, particularly in England, from the home nations, and particularly in London, housing costs are a major contributor. If you measure poverty, for example, before housing costs and after housing costs, you get higher levels of poverty after housing costs. And it seems to me I prefer to look at the after housing costs measure because that's real.
Yes.
That's what people have to pay. And that's much closer to their real standard of living. And you see, as I say, particularly in London and the South East, that poverty after housing costs is much higher than before housing costs.
Thank you. You go on at paragraph 86 to talk about trends in the Gini coefficient. Can you explain to us, please, what that is?
Yeah, I'll explain it and then say why there's a slight paradox. If you look at the incomes of every individual in the population, then if 10% of people had 10% of the income and 20% of people had 20% and 30% had 30%, the Gini coefficient would be 0. The departure from equality would be 0. But if Elon Musk had all the income in the world and the rest of us had nothing, then it would be 100%, be total departure from that line of equality. So it's a measure of the individual inequalities departing from the line of equality. The lower the Gini, the more equal the income is distributed. The higher the Gini, the more unequal. The slight paradox is that everything else in our report, we talk about quintiles or deciles. Yes. We talk about groups, not individuals. So it's a slight contradiction that we measure income inequality as individual differences, but we measure health inequality as group inequalities.
Right. Thank you for that explanation. And did you see, in relation to the Gini coefficient, a similar pattern over the UK in terms of what was happening in England and the devolved nations?
By and large, the differences don't merit too much concentration.
Right, thank you. Turning to poverty, food insecurity and destitution, relative household poverty rates measured both before and after housing costs then, again, slightly decreased at the beginning of the pandemic, but then increased again as the pandemic developed.
Exactly right. And we think the universal credit uplift played an important role, £20 a week. If you're below the relative poverty line is really very important. And we think that was part of the decline. The poverty level, we're not supposed to talk about children, families with children.
Yes.
The poverty level was around, after housing costs, was around 31%. 31% of families with children were living in relative poverty in the UK. That is worth dwelling on. That went down a small degree in the first year of the pandemic, but when the uplift to universal credit was removed, the poverty level went up again.
Yeah. And similarly, in terms of food poverty, and you deal with this at paragraph 11 of your report, official statistics indicated that the proportion of people living in food insecure households in the UK initially decreased from 8% to 6% in 2020-2021, but then slightly increased to 7% in 2021-2022, and then jumped to 11%, that's 7.2 million in 2022-2023. So does that show the same trend that you are describing?
Very, very much so.
Yeah.
And we quote the Trussell Trust that has a higher level, and I think that's because they measured food insecurity in a slightly more expansive way, being hungry, not being able to satisfy your hunger because of food, because of cost, eating smaller portions,
Yes.
skipping meals.
Yeah.
And when you measure it in that slightly more expansive way, 11 million people, said the Trussell Trust, in food insecurity.
As of 2022-2023?
Yes.
Yeah, thank you.
Could I just add as well that the jump up into 22-23 might also reflect other things happening in that period. For example, that's the beginning of the inflation on food influenced by the war on Ukraine.
Right.
And also after the pandemic, there's an increase in economic inactivity. So
Thank you.
the jump happens, but
Yes.
it's not necessarily entirely pandemic attributable.
Yeah, thank you very much.
May I add something from our global report?
Yes, please.
On inequality, AIDS and pandemics. We have a graph in the evidence we compiled for that report. In the first year of the pandemic, the wealth of the world's billionaires increased by $5 trillion. At the same time, you look at the trend of people in the world with food insecurity, it was going up. And at the same time as the wealth of the billionaires increased by $5 trillion, there were 2.5 billion people in food insecurity. Divide one by the other, you get $2,000 per person. If that $5 trillion increase in wealth had been applied to doing something about food insecurity, you could have spent $2,000 per food insecure person in the world. So what we're seeing in the UK, in microcosm, we're seeing globally in a much bigger way.
Yes, thank you. Professor Bamborough, I'd like to come to you to ask you about savings, debt and financial difficulties during the pandemic, please. At paragraph 12 of the report, you tell us that survey data found that increases in debt and rent arrears, erosion of savings and severe financial difficulties were most likely to be experienced by those in the most deprived fifth of neighbourhoods across all 4 UK nations. Is that right?
Yes, that's correct. And we've taken that from the various sources that we were able to find for the different countries. It's difficult to fully explain why, other than obviously people wouldn't have had as much savings, for example, to draw on. But also there's some evidence that suggests that it might be to do with the 5-week wait that's part of the universal credit system. So people would have to drain what small savings they had. Or there's evidence, for example, from Ulster University's report saying that people were having to go to, loans, debt collectors, people.
Yes.
To support them through that period, which happens, in what we might call normal times, but also was particularly exacerbated in that period because obviously of the employment changes.
Yes, it's perhaps worth noting that although the universal credit uplift helped many, as you've just said, Professor Bamborough, it took a while to take effect. And so for that period of time, people were still struggling.
Yes, and not everyone was entitled to the universal credit.
Yes, of course.
Including people, for example, on legacy benefits, but also other groups who wouldn't be entitled to state support regardless.
Certain migrants and groups like that? Thank
Potentially.
you. Yes. You also note, in terms of financial difficulties, there were regional inequalities evident, particularly in England. For example, respondents to the survey in Yorkshire and the Humber and the East of England and the West Midlands were more likely to have experienced a negative financial outcome at the beginning of the pandemic, April to May 2020, than those in the rest of the UK.
Yes, we draw on data there from a study by Cross and colleagues where they analysed the Understanding Society study, which is a large UK-wide survey of around 40,000 people, and we present further data showing the extent of this in Table 1.
Thank you. I'm going to come to Table 1 now, in fact, please. Can we display INQ 0000 588 215? Thank you very much, you're ahead of me. Page 23 of your report. Can you tell us, please, Professor Bamborough, what we can see in this table?
Yeah, so this is data showing different measures of financial problems, what they call negative financial outcomes during that very early period of the first wave and obviously during the first lockdown. And you can see that for each of those outcomes, the column there for the most deprived, number 1 of the quintiles, is red, indicating that they were worse than the other 80% of the population, that things were worse for them. You can also see that there were problems across all, but particularly so for people in the most deprived neighbourhoods.
We see the highest figures in that first column. Yes, thank you very much. And in general terms, did you see a similar type of pattern across the devolved nations as well?
With the data that was available, yes. And of course this does relate, this survey is available for the United Kingdom.
Thank you. Finally in this section, we can take that down now, please. Professor Bamborough, housing and homelessness. Inequalities in housing costs increased in 2020-2021. Official data showing that the proportion of household income spent on rent increased during that period in both private and in relation to social tenants. And you tell us that that was possibly due to higher rents, lower incomes, or a combination of both. There was a small reduction in the overall risk of homelessness in England, Scotland and Northern Ireland. And you tell us at paragraph 14 that that was likely a result of the Everyone In policy. But there was an increase in the need in Wales and amongst the most vulnerable groups in England. Is that right?
That's correct. We found interactions, for example, with unemployment risk and for people experiencing domestic abuse.
Thank you. You tell us at paragraph 120 that over the same period, so the beginning of the pandemic, close to 40,000 households in England were assessed by councils as being owed a main homelessness duty, which was a slight decrease compared with the previous year. What does that mean, please?
Yes, it's a way of assessing whether people are considered to be in need of support for their housing. Yeah.
But then later on, you say at paragraph 120.1, over 15,000 households with children were homeless or threatened with homelessness due to domestic abuse. And that figure was up by 14% from pre-pandemic levels.
Yes, I mean, there is other evidence from charitable groups, for example, that domestic abuse was a particular problem during the pandemic.
And are you able to comment on whether or not there is an interaction between homelessness and domestic abuse, generally and during the pandemic?
Generally, yes, and the data here that you've just mentioned would suggest that there's an interaction during the pandemic as well.
Thank you. The inquiry has received a witness statement from Tim Gutteridge, who is the Chief Executive of Shelter, the charity for homelessness. And he tells us that in terms of overcrowding, which it was clearly a problem during the pandemic because of the close proximity in which people were living, that appeared to be more prevalent in the rented sector than for owner-occupiers. He says that during the period 2021 to 2022, 170,000 households were overcrowded, those households being owner-occupiers, compared with 325,000 such homes of private renters, private renters, yes. Do those figures accord with your understanding of the problems that were persisting during the pandemic?
Yes, in terms of the evidence that we looked at, for example, with the inequalities there, for example, in rent, then there's a difference between renters and people who own their own homes. And that might be obviously to do with people's income and family size and so on, but also to do with some of the aspects, for example, that mortgage companies put in place to support, their customers in effect.
Yes.
And
Could I add?
Yes, please.
It's worth distinguishing between the social rental sector and the private rental sector.
Yes.
In general, the quality of housing is higher in the social rental sector than in the private rental sector.
Yes, thank you. I'm going to turn now to part 2 of your report, Health Inequalities During the COVID-19 Pandemic. And Professor Marmot, I'll turn to you, please, if I may, to provide an explanation of the limitations in interpreting data. At paragraph 149, you say that it should be noted that due to different deprivation indices and other reporting practices across the 4 nations, the data presented in this section of your report needs to be interpreted with some caution. Is that right?
That's correct. I should add that the quality of data in the UK is astonishingly high. I mean, we were blessed through the pandemic with very good data in general. So any limitations here need to be put in the context that the data we had in the UK were much better than in most other countries.
Well, that's good to hear. You tell us...
It's the first time since I started this inquiry I've heard a compliment about the quality of the data we have in this country.
Well, I've done a lot of work in other countries, and we're just blessed with good quality data.
At paragraph 150, you explain that area-level deprivation is a way of measuring how well-off or disadvantaged a local area is in terms of factors such as income, jobs, health, education, crime, access to services, and the local environment. How then do you use the area-level deprivation measurement in terms of mortality? How do those two interact?
So let me make a couple of comments about it. Firstly, it seems odd to have an index that's got health in the index when you're looking at the relation between this index and health outcomes.
Yes.
That sounds like confusion. It is. But if you take health out of the deprivation index, it doesn't make any difference to the relation between deprivation and health outcomes. So it sounds like a tautology, but it is not. Because, as I say, if you remove health out of the deprivation index, the remaining 6 indicators correlate very highly with health outcomes. The second is we use deprivation of the area because it's there. We can measure it, so for convenience.
Yes.
We use it in 2 ways. One, as a proxy for individual circumstances, and it's a proxy. So not everybody who lives in a deprived area is deprived.
Yes.
Not everybody who's poor lives in a deprived area. They could live in a relatively affluent area, local housing, whatever. So it's not perfect. We use it as a proxy. It works pretty well. But it can also be used to tell us something about the area.
Yes.
When that's the right measure. You don't want to measure individual education. If you're trying to understand area effects, you want to measure deprivation of the area. So with those caveats, it works remarkably well. It's a pretty good proxy for individual socioeconomic position, because if you do measure education, income, occupation of individuals, you get pretty well the same relationship you get with the deprivation of area of residence.
Yes. Thank you. Well, we're going to take a look at the various areas of the UK. And first of all, please, could we have on screen INQ 000 588215, page 32, and it's your figure 2. And this is in England, so the COVID-19 mortality rates by deprivation quintile, where 1 is the most deprived and 5 is the least deprived. So what do we see here, Professor Marmot?
Well, we said right at the beginning of the pandemic, before we got the data, when people were saying that COVID will be no respecter of social position.
Yes.
Prince and pauper alike could get COVID. And we said, yeah, maybe. But the experience of other pandemics is that it will expose the underlying inequalities in society and amplify them.
Yes.
I quoted Camus, La Peste. That's what he said. He said it better than I did, but that's essentially what he said. And you look at this figure, that's what we predicted. There was a social gradient in mortality, and we'll come on to that in a moment. Before we even knew there was such a thing as COVID, then COVID comes along. That doesn't look like it's affecting prince and pauper alike. It's a social gradient.
Yeah.
The greater the deprivation, the higher the COVID mortality. And it's really striking. Then the question is, why does it get less over time? And we'll come on to that, but we think society put in place control measures.
Yes.
Lockdown, mask wearing, and then finally the vaccine.
Yes.
So the control measures made a difference to the inequalities.
And digging in a little deeper, there were regional inequalities within England, weren't there? You tell us at paragraph 16.1 that the cumulative death rates were highest in the northwest of England, in London, in the West Midlands and the northeast.
So London was an interesting exception to the kind of prediction that I made. And it's good to get things wrong, because then you learn something. And I think the reason London was relatively high is because everybody's moving about, coming from abroad. There's a lot of mixing. It's very crowded. As I say, people coming in, bringing viruses in. Initially, people were bringing virus back from skiing holidays and the like, which only the more affluent do. And we saw the same in the United States when New York initially was very high for COVID.
Yes.
Apart from that London exception, the high rates in the northeast and the northwest were exactly what we predicted.
Yes.
Because that's what we saw pre-COVID.
And what you tell us about that is that the most deprived local authorities in the north of England, in the northeast, the northwest and Yorkshire and the Humber, had 14.5% higher COVID-19 death rates than equally deprived areas in the rest of England.
That's right. And again, that's a continuation of a pattern that we'd seen pre-COVID. In my 2020 report, Health Equity in England, the Marmot Review 10 years on, we pointed to the fact that for a given level of deprivation, as measured by the National Index of Multiple Deprivation, the consequences for health, both life expectancy and healthy life expectancy, were bigger
Yes.
in the northeast and the northwest, Yorkshire and Humber, than they were in London and the southeast. So when we saw that with COVID, we said, yep, that's what we saw pre-COVID.
Predictable, yes.
It's got a term to describe it as the amplification of the effects of deprivation that we can see in the north, and also you can see it in Scotland as well.
Yes.
In terms of health outcomes, and also here with COVID as well.
Thank you. And we're going to turn and look at in a moment at another table which I think demonstrates that. But before we do, let's just look at the other areas of the UK, please, in terms of COVID-19 mortality. And figure 3, please, at page 33 of the same report. You can see at the bottom of the page. That's regions of England. Figure 4, please, which is at page 34. We can see thank you very much. That's Wales. Does that, in general terms, show the same pattern?
It does, and just to make the point again, that it's not poor people versus the rest.
Yes.
It's a social gradient.
Yes.
People in quintile second from the top, number 4, have a higher mortality than those at the top.
Yes.
It's not much bigger in number 3, but number 2 and then number 1.
Yeah.
So it's a social gradient.
Thank you.
And again, as in England, it got flatter over time.
Yeah. And then Scotland, please, which is figure 5. The same pattern again.
Yeah, and you can see the gradient very clearly, and it flattens over time.
Yes. And then finally, figure 6 at page 36. Now, this is a different graph. Is that because the data that you received in terms of Northern Ireland was different data?
Yes. Yeah.
But we see that the mortality rate for the first quintile is the highest.
And again, it's the highest. In fact, the gradient's not quite as clear as with the other nations, but it pretty much, the 3 in the middle are intermediate between the poorest and the richest.
And the data was only available for 1 year for Northern Ireland.
Yes. Thank you very much. Thank you. We can take that down. Now, Professor Bamborough, I want to return, please, to intersectionality and the syndemic, which you have described to us, and ask you about the 5 key pathways through which inequalities occurred. Can you explain to us what they are, please?
Yeah, when looking at inequalities in COVID-19 deaths and hospitalisations, then you can look at 5 different things. One is the higher risk of exposure, for example, for people who are key workers still going out to work, and these tended to be people from lower skilled or low income groups and people from ethnic minorities, interacting with that. Then you have the transmission, which we've touched upon with the evidence, for example, about overcrowding, but also that deprivation more likely to concentrate in urban areas, including, for example, London, that Michael's just talked about. Then there's the vulnerability. Once someone has an infection, then people from low economic backgrounds are more likely to have pre-existing comorbidities and clinical vulnerabilities. That means that obviously the disease can have a worse outcome. There's also evidence to suggest that people in more difficult circumstances are also more susceptible to the adverse impacts of viruses. Evidence from flu, for example, showing that their immune systems are eroded through living in poverty. And then finally, which we will touch upon later in the section, is around inequalities in terms of treatment, particularly in terms of uptake of the vaccine, for example.
Thank you. Could we have on screen, please, figure 8 from the report, which is at page 39. And I'm going to return to you, please, Professor Marmot, to ask you about all-cause mortality by area-level deprivation. What do we see in this chart, please?
What we see is pretty much what we predicted at the beginning.
Yes.
The pandemic would amplify the inequalities. So if you look at 2019, the blue, or whatever you call that colour, dark blue at the bottom.
Yes.
And then the next year, the first year of the pandemic, in England, in Wales, in Scotland, particularly, you can't quite see it in Northern Ireland, but in the other three, you see a very clear increase in the absolute inequality. So where this is a way, later we'll get onto the gradient, but this is a way of measuring inequality as the difference between the least deprived and the most deprived quintiles, 20%. And you can see the big increase. What you can also see is that the absolute inequalities are bigger in Scotland than they are in England. And it's what Claire said a moment ago, that what I described, Claire used the term the amplification, what I described, that the consequences of deprivation for your health are worse in the northeast and northwest of England, and they're worse in Scotland.
Yes.
I think it's the same kind of phenomenon that we're seeing here. So we see the big increase, particularly in the first year of the pandemic, and this is all-cause mortality. This is not COVID. The COVID's important, but this is all causes.
Yes.
And we see it happened in all four nations, and bigger in Scotland.
Thank you. Yes, can we take that down, please? Moving on and away from mortality to talk about inequalities in life expectancy and healthy life expectancy, please. Could we please display figure 9 at page 43 of the report, noting that this relates to life expectancy only, not healthy life expectancy. So could we, thank you very much. We can see that this is entitled Absolute Gaps in Life Expectancy for Males and Females, separated out, males are blue, females are orange, pre-pandemic between the most and least deprived local authorities. So we're dealing here with before, the period of time before the pandemic hit.
Yes, and it shows an interesting phenomenon that we don't, I don't completely understand, that inequalities, in general, there are some significant exceptions, but in general, the social inequalities in health are bigger in men than in women. And I say I don't completely understand it. And the exceptions are really interesting and important. That will come on to healthy life expectancy in a moment, but also in my 2020 report, pre-pandemic, what we saw was that, if anything, the impact of austerity on health was bigger on women than on men. And so I say the exceptions are interesting. And it was pointed out to me, I didn't say it, but it was pointed out to me that the impact of austerity on women's circumstances was bigger than it was on men. The austerity hit women worse than it hit men. And we saw it in the mortality statistics, the life expectancy statistics. So I say that this general pattern we see for reasons that I don't completely understand, and the exceptions are interesting.
So just so that we understand, life expectancy at birth is a statistical measure of the estimate of the average remaining years.
It's an artifact. It's a convenient artifact. Forgive me for this. It's saying if you had a theoretical population, people, and to take today's age-specific mortality rates, the rates that apply today, and assume that as that group of people moved through life, today's age-specific mortality rates would apply to them. And then you sum all that up and you say that's the expectation of life. It is not a prediction of what would happen in the future. Children born today may have much longer life expectancy than these figures would suggest. if something dreadful happens, it might be shorter life expectancy. But it's a statistical summary of today, and it's a very useful summary. So having said it's an artifact, but we use it all the time.
But healthy life expectancy is something different. That's the average number of years that a person can expect to live in good health, not impeded by disabling illnesses or injuries or poor health. Is that right?
That's correct. And were those data readily available all the time, we would use them all the time, because in a way it's a more meaningful measure. People want not just to live a long time, they want to be healthy for a long time. And living a long time with ill health is less desirable than living a long time in good health. So that healthy life expectancy is a meaningful measure. And, you're probably going to ask me this in a moment, the inequalities in healthy life expectancy are much bigger than the inequalities in life expectancy. And what that means is, if you're living in a more deprived area, not only can you expect fewer years of life, you will live more of those fewer years with ill health.
Yes.
So that's a dreadful inequality. Not only do you have a shorter life, you have more of that life spent in ill health.
Well, let's have a look, please, at the healthy life expectancy figure, which is figure 10 in the report at page 43. So this is the absolute gaps in healthy life expectancy, again, for males and females, pre-pandemic, between the most and least deprived local authorities. So what do we see here?
So we see that they're bigger.
Yes.
If you remember the previous figure, it was around 9 years for life expectancy. Now we're talking around 18 to 20 years for healthy life expectancy. So the gaps are bigger. And when I said that in general, men are affected by social inequalities more than women, but the exceptions are really interesting. Here's an exception. What we've seen consistently is women have more ill health. They live more years on average, but they have more ill health. And again, we saw pre-pandemic, which we think was a consequence of austerity, that women's healthy life expectancy particularly did not improve because of the increase in ill health. And here we can see for England and Wales and Northern Ireland, not for Scotland, that healthy life expectancy gaps are bigger for women than for men.
And throughout the pandemic, were these patterns replicated in terms of life expectancy and healthy life expectancy?
By and large, yes.
Thank you. Professor Bamborough, I'd like to ask you, please, about long COVID by area level deprivation. And you deal with that at two areas of the report. I want to ask you about the definition of long COVID, which the inquiry is familiar with. It's defined by the National Institute for Health and Care Excellence, NICE, as signs and symptoms that continue or develop after acute COVID-19. Is that right?
That's correct.
And what did you find in terms of the available data on long COVID? What did the data tell you about patterns across area level deprivation?
Thanks for raising this point, Kate, because I think it's very important that we remember that people are still suffering from long COVID at the moment. And what we found in the analysis that we present in the report is that basically in deprived areas, the prevalence of long COVID is around twice as high as in the least deprived areas. And we got that from two different survey sources that reinforce each other. That's for England. And we also found data that showed a similar pattern for Scotland and to a slightly more nuanced extent in Wales.
Thank you. Can we put up figure 14, please, from page 49 of the report? And we can see that this is per English region as of March 2023. And does that support the evidence that you've just given, Professor?
Yes, so that shows that the North East and the North West and the West Midlands have as of 2023, had the highest prevalence of long COVID, and that potentially also reflects the patterning of deprivation as well.
Thank you. Professor Marmot, as a connected issue, I just want to ask you about employment and the data that you have looked at in terms of what level of danger key workers were placing themselves in terms of perhaps being more exposed to the virus than others. Is it important to look at the type of employment that somebody was engaged in, as well as the area that they were working in terms of geographical area?
Indeed, as you said earlier, my third recommendation in 2010 report was employment and working conditions. Employment and working conditions are fundamentally important for health. Unemployment is very bad for health. Work is much better than unemployment, but the quality of work really matters. And we know, particularly psychosocial working conditions, shift work, long hours, job insecurity,
yes,
high demand, low control, effort-reward imbalance, poor organizational justice, all increase physical and mental health. And all of that would operate during the pandemic. Then, in addition to all of that, you've got people working in frontline occupations.
Yes.
Forgive my coloured language, but the heroes who are coming to collect your garbage, who were serving as cashiers in the supermarket. These were the heroes of the pandemic, putting themselves at risk by helping society to function.
Yes.
So in addition to all the other things that we know about that would be operating during the pandemic, there's then exposure to the virus because of the nature of work. And the inequalities are key, because people who could work from home and do their work without interruption were not exposed in frontline ways like that. So that was on top of all the other things, yes, connected with work. That was an extra risk.
Thank you.
And could I also add that obviously people in those lower paid roles as well were also less able to access sick pay, which we did discuss in our first Module 1 evidence, yes, which would have meant that they were potentially working with symptoms of COVID and also, potentially spreading it because they weren't able to afford to take time off.
Yeah, and being placed in that level of deprivation was not in any way going to encourage people to disclose their COVID symptoms.
Well, you'll remember during the pandemic when there were these ill-fated tiers
yes,
of risk, and in Manchester and the Northwest, yes, there was the concern that if people weren't compensated, they were told, if you've tested positive, stay home. Yeah. We won't give you any money, but stay home. Well, that was a pretty strong disincentive to get tested.
Yeah. Thank you. Professor Bamborough, you deal within the report at paragraph 215 with inequalities in health-related outcomes. Mm-hmm. And you list several of those: alcohol consumption, smoking, physical activity, obesity, and loneliness. Just touching upon one of those, please. You talk about the alcohol harm paradox. What do you mean by that phrase, please?
So that means that even if you have the same rates of drinking amongst more educated groups versus lower educated groups, there's more harm for people who are on the lower income, lower educated end. So,
why is that?
I think, I'm not sure we have the answer, which is why it's called a paradox.
Yes.
But the speculation would be around how the drink is consumed. So, for example, high prevalence of binge drinking, but it also will probably, in my opinion, interact with the other social determinants that Michael's outlined and draws into that idea of one of the pathways around susceptibility and in effect, the physiology of the body as well.
Thank you. Well, going back to the pathways, could I ask you to tell us about unequal treatment, because that is something which you've already mentioned. I think it was the fifth of the 5 pathways. What does your research tell us about that?
So, are you wanting me to discuss the vaccination programme? I'm sorry, I'm not sure.
Well, I'm wanting to move on to protections and mitigations.
Great. Okay, that's
so
fine.
Let's deal with vaccinations as the first one.
Okay, yeah. So I know that Milady's had a lot around the vaccinations, but there's been later studies showing the impacts on inequalities in COVID mortality, and there's a strong association over time that the rollout of the vaccine was effective in reducing the social gradient, as we saw earlier with the graphs and Michael's commentary. However, it didn't eliminate the COVID mortality gap.
No.
Modelling suggests that was because of the unequal uptake, and you can see with the first, second and third dose increasingly people from more deprived areas have a lower take-up of the vaccine, and that's something I think is a very important point for us to make, is that the vaccines were working in terms of reducing mortality, but that we need to do more to ensure that everyone takes up that offer, including at the moment people in more clinically vulnerable groups who are still entitled, for example.
Yes, thank you.
And could I just add
please.
the global perspective? There was huge inequalities globally in access to the vaccine.
Yes.
Low and middle income countries had less access than high income countries.
Thank you. We've already touched upon housing policies, the Everyone In policy, and how that assisted. But the inquiry has received evidence that, of course, when that scheme stopped, when it finished, did things go back to how they were before, or was there any retention of benefit to the homeless?
So I think what you find is that you then get, for example, evictions went down in that sort of early pandemic period where there were pauses due to legislation, but then they go back up again and in fact increase and perhaps compensate for the suspension. And we can also see this with other aspects. For example, with the £20 uplift in universal credit, when it's taken away, then the increase in poverty that you get in the later period that Sir Michael outlined earlier is likely associated with that reversal of policy as well.
Thank you. And we've also touched upon universal credit, and you've already told us, Professor Bamborough, that one important consideration is, of course, that not everybody would have been entitled to that mitigation. And so the benefit that had, of course, only attracts to those who were entitled to
it would only attract to
it.
those who are entitled. And in the report, we talk about some of the groups that were less likely to have that. And that did include, for example, people who've been on legacy benefits for a long time, such as certain groups of disabled people. Yeah,
thank you. Professor Marmot, you've already discussed or touched upon lockdowns and how that helped reduce the gap in COVID-19 death rates. Is there anything else that you would like to say about the difference in the timing of the lockdowns, or shielding, or social distancing, and how any of those mitigations assisted?
Well, I would, in general, I would hope that one of the things that will come out of the inquiry is we get a judicious view of the balance with these protective measures. I think all of us at the time were concerned that to get the balance right.
Yes.
On the one hand. On the other hand, you close schools, children will suffer. You stop workplaces, people will suffer. On the other hand, you let the virus run rampant,
Yes.
and you get high mortality. So I hope we'll get some reflection of that. But what it does show, I mean, my fundamental view that I've tried to express is that there are deep-seated social and economic inequalities in society that lead to inequalities in health. What these data show is specific interventions,
Yes.
vaccination, protective measures can reduce those inequalities. Wow, that's pretty good. That's a
Yes.
good lesson to learn. And the fact is these protective measures applied equitably can reduce inequalities. Very important. So we, in learning this very important lesson, we need to get this balance right.
Well, that brings us very neatly on to lessons learned, which you deal with beginning at paragraph 328 of your report. The first of which is to reduce health inequalities in pandemics. We need to reduce health inequalities outside of the pandemic period and before the next pandemic or civil emergency occurs. The phrase that you use, and I know that you used this last time, Professor Marmot, when you were here, is to fix the roof whilst the sun is shining. You've touched upon government actions to mitigate and how those assisted, but I'd like to ask you about pandemic planning and implementation, which you say should integrate a health equity lens across all aspects of the process. What do you mean by that?
Well, what we said in Module 1, and it was amply supported by the council that I co-chaired on inequality, AIDS and pandemics globally, the
Yes.
Global Council, that to prepare for pandemics, you need to have less social and economic inequalities in society because they lead to social and economic inequalities in health. And that was a key driver of the problems that we had, which is why in the early phases, mortality was so high. And we said this in our global report. We even got the G20 in a ministerial statement to say, to prepare for the next pandemic, countries have to invest in improving the social determinants of health. So a key message is that we should not limp into the next pandemic with the same levels of social and economic inequalities that we limped into this pandemic.
And what about those who suffer from particular either disabilities or clinical vulnerability? Do those sections of society need to be protected?
Well, let's look at disability first.
Yes.
What we've shown when we've looked at it in all our reports is that people with disability are more likely to have adverse exposures to the social determinants of health, whether it's from early childhood, education, employment conditions, income, housing. All of our social determinants of health apply even more so to people with disability. So
Yes.
they're more exposed. They may also, to come back to what Claire laid out in her our five pathways, what Claire laid out, they may also, either because of the ill health that caused the disability or because of ill health that's a consequence of the disability and
Yes.
social determinants, be more vulnerable. And I would then apply that to other subgroups in society. And we were asked not to look at other forms of inequalities, but they apply to other subgroups in society.
Yes, that was because I know that my lady is going to be receiving expert evidence from others who have looked specifically at those areas. But does that come back to intersectionality, that all of these aspects of difficulties and those that those in society who are the most vulnerable need to be looked at together to determine what level of protections and what type of protections need to be added.
I think it comes back to the fact that inequalities weren't thought about in the preparedness and the planning,
Yes.
in SAGE. I noticed in Neil Ferguson's evidence, for example, that's in position for today, that
Yes.
he said that they didn't think about deprivation and the dynamics that might have on the transmission of the disease in that quite significant modelling that they were doing. So that's what we mean when we're talking about the health equity lens, is to actually consider that people are different.
Yes.
And that might have impacts on their experience of a civil emergency like a pandemic.
Thank you.
Because there's I don't want to get philosophical in giving evidence, but there are a couple of different reasons for classifying people in the way we do.
Yes.
One is if that's a target of intervention. So if people are rough sleepers, you classify them as rough sleepers because rough sleeping's not good for your health. And that's the target of intervention. If people are below the poverty line, we describe them in that way because it's not good for their health, and if we could get them above the poverty line, their health would improve. So that's one reason for it. The other is it's a guide to the conditions that we think are what's determining their health.
Yes.
You could say, well, somebody's got to be in relative poverty. What's wrong with that? Well, to the extent that it's a guide to poorer education, to poorer working conditions and all the other determinants, it's a way of looking at what's needed. So the intervention could be on the descriptor, low income.
Yes.
Belonging to a particular subgroup, disabled, minority ethnic, whatever that could. But you can't change minority ethnic. What you can change is the conditions that attach to that descriptor. And that's what's important. So we're trying to do both of those things.
Thank you. And just to come back to your international work and the work on the council that you've mentioned, looking at AIDS and pandemics, is what you have found looking at the United Kingdom similar? Are the patterns the same by and large to what you have found on that international council, looking at countries such as Sweden and Brazil, and I know elsewhere as well?
The graphs that you put up on the screen, we could have put up an almost identical graph from Sweden or from Brazil that would look the same. So where we had data, and my earlier comment about the quality of our data is we don't have such good data from most other countries. But where we had those data, we saw the social gradient in all the things that we've been discussing here. The inequalities that led to worse pandemics and the impact of the pandemic on inequalities. So everything we've concluded here is consistent with what we found in our Global Council, not only because I was co-chairing it.
Could I just
Yes.
add a little bit on the data side of things, because one of our recommendations is to still further improve the data.
Yes.
Because I accept what Sir Michael's saying in relation, from a global perspective, but that doesn't mean we shouldn't try and do even better. And I wanted to just particularly highlight that obviously in today's report, it is quite difficult to find information on, intersections between area
Yes.
deprivation and other factors. We have very good area level data, but as Michael explained earlier, that's not the same as individual level data, and it's therefore very hard to look into what happens to other groups and during an emergency like a pandemic.
Thank you. Professor Bamborough, Professor Sir Michael Marmot, thank you very much. I think there are two questions coming from
There
other
are?
participants.
Ms Davis, who's that away?
My lady, thank you very much. My lady, before I ask the question for which I've had permission, we have just emailed STI and CTI in terms of some questions that we were told CTI might ask about migrants, those subject to domestic abuse and the healthcare charging regime. I wonder if they weren't asked. I understand that these things happen. Would you give me permission to ask one more question in relation to that area? I've reduced the 3 questions we suggested to 1.
Very well, Ms Davis.
I'm grateful. If I may start, Professors, with my first question, for which I was given permission, and I'm sorry, I should have said, my name is Liz Davis and I represent the Domestic Abuse Group, which is a group of 3 organisations concerned with violence against women and girls. You set out in your report the various intersectional nature of health inequalities, socioeconomic status we spent a lot of time on today, and also ethnicity, and groups experiencing multiple disadvantage. You said so at the beginning of your evidence, and it's referred to at paragraph at 147, but can I just confirm that domestic abuse should also be recognised as a contributing driver of health inequality?
Yes, I would agree that it's an important health matter for the women that are affected by that and would potentially intersect with other inequalities as well. So Michael and I were discussing this in the evidence room beforehand, and Michael, you had some data that you could share on that.
Yeah, in general, like most other important health outcomes, what we see is that the greater the deprivation, the more frequent is domestic violence and probably other forms of domestic abuse as well.
Thank you. And my second question, from which my lady has just been kind enough to give me permission, relates to those subject to domestic abuse who are migrants and may be considering seeking healthcare. Of course, you're aware, and I'm sorry, this is not dealt with in your report, but we did put it in earlier, that there is a healthcare charging regime for migrants. It's a condition attached to visas whereby migrants pay a certain amount in order to apply for the visa, and then there are types of migrants who may be undocumented who've not paid that and would be charged for certain secondary care. There was an exclusion for COVID-19, but other forms of secondary health care. Can I ask, the experience of the domestic abuse group is that those who are subject to domestic abuse, predominantly women who are also migrants, are deterred from seeking healthcare, both primary and secondary, as a result of that charging regime. Would you be able to comment on that? Can you agree with that?
We were asked specifically not to deal with migrants and ethnic differences, so we didn't look at it.
Thank you very much. I'm grateful. I'm grateful, my lady.
Thank you, Ms Davis. Ms Peacock, who's right down the end there.
Thank you, my lady. Professor Bambrett and Professor Marmot have already addressed my question in response to Ms Blackwell. I won't ask them to repeat their very clear evidence. I'm grateful.
Thank you very much, Ms Peacock. That completes our questions for you, Professor Marmot and Professor Bambrett. We began the inquiry hearings, seems like a lifetime ago, a couple of years ago, and I think I suspect we shamelessly used your work throughout the inquiry because we have had this focus on inequalities. So it's particularly apt that, having begun the inquiry, hearing from the 2 of you in that first week, this is our last module and you're giving evidence again. So thank you so much for all the work that you've done in helping the inquiry, for coming back again, and as I say, for work that even if we didn't call you as a witness, we probably made reference to your work in other modules. So I'm really grateful to you, and thank you for the work you do to highlight and therefore fight inequalities.
Thank you very much.
Thank you. Is that a moment to pause for lunch?
It is. We're a little early, but I won't apologise for
I suppose
that.
people would object. I shall be back at 1:45.
Thank you.